Welcome.
Thank you.
So at your hospital, you are using AI in a whole bunch of ways. And I wonder if you could tell us a little bit about how you think about that and what you think is most important and exciting about what you're doing.
Yeah, it's great that you said using it, because I actually was talking to a person on a very famous, notable Northern European hospital who's in charge of their AI. He has about 120 AI application in the health system in the hospital, but they're only using 5. So it's about, yes, using them. What we are focusing on is we need to get the system, the healthcare professionals, to be able to change a little bit faster and use these applications in the right way. How do we do that? And a lot of this has been mentioned in the previous talks here. We start by finding the right time for them. So reducing the administrative burden and helping them, get them the confidence in that one. Helping them with the diagnosis, not making the diagnosis, but helping them with the diagnosis. That's what we're doing. So the ambient listening with the coding part, which is a great sort of thing that we're using and starting to use more and more. And there are so many other studies on things that help in that way, helps, or not only the physician, but it helps the patient. There is the use of this in like I said, in diagnosis, where you need a lot of data to be sorted out, like which has been mentioned here with the mammograms, breast cancer diagnosis, which is a sort of small area, but it's where you have a lot of information. You're black or white or yes or no, and the system learns about it. The same goes with where you have a lot of information, like in genetics. It's a huge amount of information. How do you sort it out? How do you use it? How do you get the help of the machine to do that?
So thinking at a kind of hospital level, I mean, you can use AI for, little things like administrative tasks. You can use them for robotic surgery, as you seem to be using. How do you decide which ones you're going to introduce, and what is your experience with, say, using AI in surgery? I mean, that sounds like it has a lot of potential, but also a lot of risks.
Well, it's just as I said, health professionals are conservative persons, and it's difficult to have them to do things differently. But if you can use the AI system to support them or help them, then it works. I mean, the AI systems that we have in robotics, we're sort of one of the world leaders in using robotic surgery. It sounds very nice, but it's really a steadier extended arm of the surgeon that we're using.
What surgeries are you using, if you don't mind me?
We're using this for a bunch of things. We were using this for transplants. We did the first robotic heart transplant in the world about a year ago. We've done liver transplant.
And that was with AI assisted.
And the AI is there to help the surgeon when using the robot, both on giving warning signs, but also learning how this surgeon uses the machine from time to time. So AI is an algorithm of collecting data and learning from that. And this has sort of helped us in doing things. It gives them feedback, and the machine helps them going right or left and going into danger zones. But it's a complicated thing, and that's where AI helps us to decomplicate things, both in the clinical and the administrative part of the healthcare world.
So excite me about AI in administration. I mean, obviously, AI robotic surgery is very exciting, but should we be excited about using it in admin?
Oh, absolutely. It's a no-brainer, because the risks of just doing it are close to none in the administrative part. there are studies now, both coming from the US and here from the United Kingdom and the rest of Europe, that show if you use that in administration, like ambient listening and what's coupled to that, you get like 20% more time for the physician to have more patient time, and the patient sees more engagement, more satisfaction of what they're getting, instead of somebody writing down and having thoughts all the time. This is sort of, and this helps for the rest of the administration, because the administration around healthcare, and especially in hospital, it's been complicated by regulations, by you have to, this data must move this there, you have to report this and in and this out. It was mentioned here formally, all these forms, AI can solve this today. This is ready. Just, I tend to say to my people, when we're sort of thinking about it, or maybe we should do it, I said, just do it. That's been used by another company.
But so, indeed. So as you were talking about this other colleague of yours who had these hundreds of apps or AIs that you don't use, I mean, you must be approached all the time by people who are trying to sell you solutions for your hospital. I mean, how do you think about which ones you buy, which ones you take the trouble to even look at? Because let's be honest, some of them are going to take time to look at and then actually implement.
Well, there's a bias in that one. You have to have some experience on evaluating this. We've had, at King Faisal, we've had quite a few that we saw they looked promising, and when we started to sort of do a pilot with them, it completely
What was wrong
failed.
with them?
Well, the biggest part was the sort of getting them to integrate with the rest of the hospital, all these complicated systems. So healthcare is quite fragmented in how they use digital systems and everything that's been mentioned here earlier. And that's always what has sort of made them fail. And most of these companies are quite small. They don't have the bandwidth to solve these things. And then they look at us and say, can't you solve this for us? I'll give you a piece of the cake, but then you go into what takes time, and this is not our core business.
And then the ones that are successful, do they tend to be larger companies, or they've thought about it in a more holistic way? Have they used clinicians to try and inform them about workflows? I mean, what makes it work?
What makes it work are what I've seen as a trend is that if you have they can be smaller. The big ones are really slow. I mean, the big ones, they're just following the small ones or buying up some of the small ones, and even not buying always the good ones. What I see is if you have like 70% or 80% clinicians with IT, and then you have this IT guy who's sort of doing it, then it works. It's sort of my rule of thumb, and that so like maybe 60%, but 70% if they're top people have clinical background, they understand what needs to be done. They understand what's done in front of the patient.
And then, so you say you've decided that, you like the look of some new technology for your hospital. How do you kind of go about convincing your clinicians that it's a good idea, that they change everything they do and they try this new technology?
Well, that's a $1 million question. That's just not only AI, it's everything. And clinicians are really terrible in doing things differently.
And you used to be one, right? An orthopedic surgeon.
I'm guilty, sort of. And the worst thing that I sort of before becoming a sort of administrator was the reason I became administrator, I was so tired of getting orders from people upstairs. You should do this. Oh, they must be crazy. So I'll go upstairs and try to do this differently.
It's not so easy, is it?
No, it's not. But the thing is, you cannot. So it's to get engagement, not in the middle there. You have to go on the floor. You have to work with the people that are doing the job. I tend to say, sometimes it's a cliche as well, I'll say power to the people. the people that are in the front line. There's no innovation that's done in the innovation center. No. The innovation is done where the problem is to the patient is. That's how I try to solve it. So before I came to this job, I was at the Karolinska University Hospital in Stockholm, and they had a great innovation center, nice offices and stuff like that. There were about 100 people working on this. And when I came to that, I had to push a button, ring in, and make an appointment. They were working for me, and they were not doing anything because all the ideas, all this stuff, came sort of inside where the patients are. So I closed them, and we were much better when we did that. So we moved the know-how of innovation to teaching people to innovate or supporting them, and decentralizing some of these decisions.
So the King Faisal, you don't have a sort of separate center. You just it's. I mean, can you help me conceptualize how you're introducing it?
So most of these, it's like I'll have an example. One of our most famous innovation part at King Faisal was when we did the first completely robotic heart transplant. This is about 12 months ago. But 18 months ago, there's a surgeon that comes to my office and said, "Oh, I have an idea. And I want to do this and this." I said, "Yeah." I said, "Just do it." Took him 6 months. And he said, I need this support and this, and so who's stopping you?
Okay, so basically it's about a leader who is open to kind of innovating and who's willing to say yes. If a clinician kind of says, "Can we try this?"
There's always just a yes. If you have a no, you will stop them in the shoes. But yes, but find the solution to doing it. So there might be some hinders, there might be regulations, there might be stuff that computer says no. So that's not an answer. The answer is in AI and everything. So find the solution. How can we get the yes?
And then in your kind of in your hospital, how do you think about the patients when it comes to introducing innovations, and how much buy-in do you need from them? The person who was having the heart done with the first, I mean, I don't know if I would have wanted to be the first patient to have my heart replaced with a robot, or would I? I don't know. What do you say to these?
Well, as usual, it's also when you're trying new drugs or whatever, it's the same thing there. You say this has a real potential. This has a real potential. What we're doing with you, take the example of the first heart transplant. Or we're telling the person, instead of cracking up your thorax, keeping it open, and you'll be at the ICU for 6 to 8 days and in the hospital for 2 to 3 months, you'll be in the ICU for 12 hours or 18 hours. We're not cracking up your chest. And if this works, if it doesn't work, we have a plan B, opening it up and doing it differently. But of course, it has to be safe for them. But the thing is, I say also to the clinician and the patients, and they tend to say, what we are doing here is this is better for the patients. This is always, we think that what we're doing is better for you as a patient, then we're doing it.
And if you had to sort of, summarize in, 35 seconds, what you think is good about how you're approaching this technology, and what message you would have to sort of people who are thinking about moving forward, what would it be?
So in healthcare and AI and getting these things going, we just have to start doing it now. It's too late. We're too late in everything. It's the usual thing with digitalization of the healthcare. We know we're too late. We're 20 years after a lot of industries. Don't let that happen with the AI revolution. Just go ahead and do it. We have to start doing it. Of course, it has to be safe, but there's nothing that we've sort of done for our patients is 100% safe. Not with machines or with humans. But we have to have the courage to do these changes, because in healthcare, I haven't seen many radical changes in the last, if I look back, I'm not that old, but if I look back 200 years, I have not seen many radical changes in how we work.
Well, that's a wonderful thought to end on. So would you put your hands together, please? And thank you. Thank you very much.